प्रणाम। आदरणीय मुख्य अतिथियों और सम्माननीय सब अध्यक्षों को मेरा आदरणीय प्रणाम और नमस्कार। And I invite you all to this wonderful evening of TOG webinar on RH Isoimmunization in pregnancy and RPL. And we have with us the guest of honors. And I would like to welcome now none other than the giant of East India, Dr. Dilip Kumar Datta. He is an encyclopedia, the man who is all the time walking and talking. And I know him since last 25 years, since he visited Sion Hospital many times. Dr. Dilip Kumar Datta is a textbook in himself, and every managing committee, he will take permission and get a textbook out, and I'm sure you might have read it. It is spread all over nook and corner of India. He has presented more than 1,000 papers, national and international conferences, and we all know he served ICOG in Foxy 2015 and editor of the famous Journal of Indian Medical Association. We also know that he was the vice president of Foxy in the year 1999. Always humble, always talking. All the time his mind is with books, education, academics, and a man with a vision. Welcome, sir. Thank you so much. I request you to please guide and inspire this webinar, which we are going to East India, the Northeast India. Please, the mic is yours. Please say a few words. You can kindly unmute, sir.
Speak. Oh.
Yes. I think sir has some technical issue regarding his audio. Not to worry, he is there with us and we will get back to him very, very soon. Superb. We will get back to you. Thank you, sir. Now I have with me Dr. Gokul Chandra Das, the man who has also taken the East India, the Northeast India to all the Foxy platforms. And I know him personally because I have worked with him in Safe Motherhood Committee, and he has always guided me when we were working along with Dr. Shirish Patwardhan from 2003 to 2007. And sir is a very humble person. And coincidentally, it so happened that his student, Dr. Chinmay Pataki, I don't know whether he is listening today, but I am sure he was there in Guwahati. And I want to tell you that they have 70 deliveries a day. And that student came to Bombay, became my lecturer in 2009 to 2011. And sir, we were fortunate also to get you as an examiner at the famous Sion Hospital. You are a guiding force and a teacher of teachers, an encyclopedia because you are a professor and head of the department of Guwahati Medical College. And I know, sir, the way you have organized the AICOG Guwahati 2010, where with memorable, nostalgic photographs, and of course, you are also the president of the Northeast Association of Obstetric Gynec Society. Welcome, sir, and please guide us for 2 words and few sentences. Pranam, sir. Thank you. Please unmute your mic.
Pranam. Best wishes. Best wishes for this good conference, and my best wishes to all my fellow colleagues, and wishing them all the best.
Yes, sir.
Wish all the best to the speakers, and we'll listen to them.
Thank you.
Thank you.
Sir, and I will be coming back to you for few comments and few expert comments in the meantime. I hope Dr. Dilip Kumar Datta has joined, sir, our chief guest. I hope you can unmute your mic and you can give your sermons of wisdom. Dr. Dilip Kumar Datta. I think we have lost the contact and it's the frozen window I can see. So with this, we will go ahead and introduce ahead. So I would like to call upon my esteemed panelist. Dr. Anita Singh is going to join us. She is the current Vice President of Foxy. She was the ex-professor of Patna Medical College. Can I get the next slide, please?
Hello.
And yes,
Hello.
yes, hello, sir. Dilip Kumar, sir,
Hi.
please go ahead. Please
Yes,
go ahead. Please
So,
give your
thank
address.
you very much.
Inaugurate this webinar. Thank you.
Yes, thank you. Thank you. So thank you very much for inviting as a chief guest. I inaugurate the seminars. I know all the stalwart is sitting there. My bosom friend Gokul Chandra Das is there. Sumna Singh, Anjan, everybody is there. So without wasting my time, please start these seminars.
Yes, thank you, sir, for those wonderful words of encouragement. And sir, please be there because we want to hear from you. Thank you so much. Now, we will go ahead with the introduction of our speaker and the panelist. And I can have the slide of Dr. Pragya Mishra Chaudhary. We know her. She is the chairperson of Genetic and Fetal Medicine Committee from 2016 to 2018. She has her own hospital. And she is an IVF consultant and presently the secretary of Patna Obstetric and Gynec Society. Welcome, Dr. Pradnya. Can we have the next slide? Thank you. And I want to introduce also my panelist, Dr. Abharani Sinha. Madam is so wonderful to talk to. Same like Pragya Mishra, madam. She was the president of Patna, chairperson of the quiz committee Foxy 2017, has a teaching experience of more than 25 years, an executive member of the National ISOPA. Welcome, madam. We will catch up with you, all of you, soon after the lecture of Pragya Mishra, madam. Dr. Priyankur Roy, the budding big man, which I met in Ahmedabad during the Eurogynec conferences working with Dr. Vinit Mishra. He doesn't require any introduction, but presently he is at Siliguri and he is also representing us, Foxy in Siliguri, and he has delivered Dr. Kaminira oration and he has published many articles, and we see him as a consultant of infertility and endoscopy in Genome Siliguri, fellowship in infertility, gynae endoscopy, Foxy. Welcome, Dr. Priyankur Roy. Dr. Anjana Jha, we can see her today. Thank you, madam. So nice to see you. I know you very well. You are the head of the department and you were the past treasurer, secretary and the vice president of Ranchi Obstetric Gynec Society. Presently, you are an executive member of ROGS, joint second treasurer of ISOPA Ranchi. And madam, we will be hearing the pearls of wisdom from you. Warm welcome to all of you. Thank you. Now, I want to introduce the man with the vision. Last year, he had wonderfully, last year, he has wonderfully presented the UA Foxy. He represents the UA. Priyankur and Hafiz Roy, Rahman, they represent the UAs of the Northeast, and we want them to come in Foxy because they are really good in nature and good in their work. I have seen with my own eyes last 4-5 years. He is a professor of obstetric and gynecology from Sikkim Manipal Institute of Medical Science, more than 50 scientific research, founder, secretary of Gangtok Obstetric and Gynecological Society. And we all want to come and visit Gangtok, Dr. Hafizur. Last time it was not possible, but all of us, more than 500 delegates from all over India are going to come, and we are going to give that opportunity to you once the corona is over. See you soon. Thank you so much. And lastly, we have got Dr. Soman Sinha. He is a consultant gynecologist, ex-consultant gynecologist, HOD obstetric and gynec in the Ranchi Medical Hospital. Also, she has got a lot of awards to her. She was the secretary, the vice president of Ranchi Obstetric and Gynec, and she is also going to participate in this panel discussion. So with this small introduction, I would not like to be anywhere in between you all, the users and the delegates of TOG webinar. And we will hear from Dr. Pragya Mishra.
So I'll start sharing my screen.
Yes, please start sharing your screen. जैसे कि हम सब लोग जानते हैं कि सुबह से लेकर रात तक हमारे हर काम में विज्ञान है, विज्ञान से ही अछूता नहीं रहता, एंड्रॉइड फोन से लेकर फैन, हर एक चीज में विज्ञान ही तो है. विज्ञान is what we are going to discuss today. RHIC immunization, and I present to you Dr. Pragya Mishra Chaudhary in front of you to deliberate on RHIC immunization. Pregnancies.
Yeah.
Thank you.
Yeah. Thank you, Dr. Niranjan. Can you see my screen now?
Yes, madam, we can see your beautiful picture and your biodata too. Good.
Okay. Okay. Yeah. A very good evening to all of you. Respected guests of honor for today's TOG webinar, which is Dr. Gokul Chandra Das, Dr. Dilip Kumar Datta sir, and Dr. Mrs. Anita Singh, who I think would be joining later on, and the esteemed moderator of today's TOG webinar, and Dr. Niranjan Chauhan, and who is also the National Coordinator of Medical Disorders in Pregnancy Committee. So thank you first of all for the very kind words that you have spoken about me. And at the outset, I would like to thank the Medical Disorders in Pregnancy Committee Chairperson, Dr. Komal Chauhan, and the National Coordinator, Dr. Niranjan Chauhan, for having invited me to give this lecture in front of you. I'm going to talk on rhesus negative pregnancies, which I think, well, most of us know, most of it, I mean, all of, basically we know quite a lot about it, but I don't know, somehow it's one topic which I feel the need that there is a need to refresh it all the time, now and again. So hopefully, the attendees, our esteemed attendees, are going to enjoy the session. Hoping so. So rhesus factor is a protein found on the red blood cells of most people. Now, when a person does not have this factor, they are called Rh negative, as all of you know. Now, when a Rh negative mother is exposed to Rh positive red blood cells, she may produce antibodies in her blood, which is called isoimmunization or alloimmunization. Now, what these antibodies do, they cross the fetus across the placenta and form complexes with the Rh positive fetal red cells. And these affected RBCs get destroyed by the reticuloendothelial system of the fetus. Now, there are numerous antigens on the surface of Rh positive red cells, which have been, placed into groups. So the rhesus antigen constitutes at least 3 very similar transmembrane proteins called C, D, and E. And D is the most important antigen, and other Rh antigens can provoke antibody formation such as anti-E and anti-C, which most of you would have heard of, because these can also lead to hemolytic disease of the newborn. There are some non-Rh groups such as KEL, MNS, and KID, which also have assumed increasing importance since they could produce red cell antibodies as well. Now, globally, the Basque population of Spain has the highest incidence of Rh negativity, which, you would be surprised to know it is about 30 to 35%. And as you can see, whites have the incidence about 15 to 16, Native Americans 10%, Africans 8%, and Black Africans 4%, and Asians and others 2% or less. But as far as my knowledge goes, I think in India it is about 5%, the incidence of Rh negative is about 5%. So there are 2 common systems for blood group classification, ABO system and the Rh system. ABO system comprises of groups AB, AB and O antigen, and the rhesus system comprises of C, small c, D, E, and small e. So just to tell you, there is no D antigen, small d antigen. The letter represents absence of D. The D antigen is considered to be the most immunogenic. Now, coming to the pathophysiology, now what happens? Now, you can look into the picture. If the father is Rh positive and the mother is Rh negative. Now, it depends on whether the father is heterozygous for the D antigen or he is homozygous. So, heterozygous means he has just 1 copy of Rh D gene, In that case, only 50% of the children would be Rh positive, and 50% of the children would be lucky to be Rh negative, since the mother is also father is homozygous for the D antigen, which means he has 2 copies of RHD gene. In that case, all children would be Rh positive. So 100% would be Rh positive if the father is homozygous for the D antigen. So coming to fetal-maternal hemorrhage and Rh incompatibility, now the amount of fetal blood necessary to produce Rh incompatibility varies, but you would be surprised that as little as 0.1 ml of Rh positive cells have been documented to cause Rh incompatibility. And studies have suggested that up to 30% of people who are called non-responders with Rh negative blood never develop Rh incompatibility, even when challenged with large volume of Rh positive blood. But that is mainly due to some genetic alterations in their antigen. Now, Rh alloimmunization occurs by one of 2 mechanisms. One is after incompatible blood transfusion, and secondly, it is because of fetal-maternal hemorrhage during pregnancy. Now, fetal-maternal hemorrhage may occur during pregnancy, and the incidence is about 10%, and it can occur during delivery, which is about 90%. And fetal RBCs have been detected in the maternal blood in all the 3 trimesters without an apparent predisposing factor. The initial maternal response to Rh sensitization is low levels of IgM antibodies. So these are confined to maternal circulation, reason being because they are high in molecular weight. Now, whereas within 6 weeks to 6 months, IgG antibodies are formed, and these are small in size, and so they are able to cross the placenta and destroy the fetal Rh positive cells. The firstborn infants with Rh positive blood type are not affected. The reason is that the short period of first exposure of mother to fetal RBCs is insufficient for production of significant IgG antibody response. Now, as you can see, that as the trimester it goes from first to second to third, the incidence of fetal-maternal hemorrhage, as you can see in the graph, it increases from 0.7 ml in the first trimester to 0.13 ml in the third, and almost 0.19 ml at the time of delivery. But on an average, at least, about 0.5 ml of fetal-maternal hemorrhage occurs at the time of delivery. Now, these are some of the potential sensitizing events, as you can see, during the antepartum period, intrapartum, and postpartum period. Now, what is the grandmother effect or theory? This is quite interesting. Now, in all pregnancies, small amounts of maternal blood enter the fetal circulation, and real-time polymerase chain reaction has been used to identify maternal D positive DNA in peripheral blood from preterm and full-term D negative newborns. So possible for a D negative female fetus exposed to maternal D positive red cells to develop sensitization. So when such an individual reaches adulthood, she may produce anti-D antibodies even before or early in her first pregnancy. So this mechanism is called the grandmother effect of theory, because the fetus in the current pregnancy is jeopardized by maternal antibodies that were initially provoked by his or her grandmother's erythrocytes. So the hemolytic disease of the fetus on the newborn, the sequence of in utero events, as you can see, first of all, the maternal IgG enters the fetal circulation via placenta. There is destruction of fetal red cells, leading to fetal anemia, and the hematocrit can go down to less than 30% or even less than 15% in cases of fetal hydrops. A heme is formed and converted to bilirubin, which leads to fetal hyperbilirubemia, and both are neurotoxic, but effectively cleared by the placenta, metabolized by the mother. So extramedullary erythropoiesis is stimulated because of this breakdown of RBCs, and immature erythroblasts are produced. Now, when red cell destruction exceeds production, severe anemia occurs, There is more demand on extramedullary sites to produce more red cells, leading to hepatosplenomegaly, and heart failure eventually results with ascites, edema, and pericardial effusion, leading to erythroblastosis fetalis, which was the older term. Now, hydrops fetalis occurs when the hematocrit falls below 15%, as I just mentioned in my last slide, and that often results in fetal death shortly before or after birth if not treated. And the ratio of hydrops between male to female fetus is about 13:1. So this is just the sequence of events in development of the hemolytic disease of the fetus and the newborn, which I just, enumerated to you. The RH sensitization risk, the risk and severity of sensitization response increases with each subsequent pregnancy involving an ABO-compatible fetus with RH positive blood. Now, without prophylaxis, this risk is as high as 16% after 2 deliveries. So 1.5 to 2% occurs antepartum, 7% within 6 months of delivery, and 7% manifest early in second pregnancy. Whereas with prophylaxis, the risk drops to 0.1%. So you can understand that if there is inadvertent, if people don't use anti-D, or if there is omission of anti-D, so the risk of immunization can be as high as 16%. The sensitization risks depend on the 3 main factors. One is the volume of transplacental hemorrhage, the extent of the maternal immune response, and the concurrent presence of ABO incompatibility. So let me tell you that ABO incompatibility is protective. So it is good for the fetus, and the risk drops to 1.5 to 2%. And RH incompatibility is only of medical concern for females who are pregnant or are planning to get pregnant. The objective of antenatal management is prevention of RH alloimmunization in the RH negative unsensitized woman, early detection and treatment of fetal anemia in the sensitized woman, and sensitization is determined via the indirect Coombs test, the ICT, otherwise called antibody screen test. Now, what happens? Now, if basically, in a nutshell, as you can see, that if the mother is RH negative, then you go for maternal antibody screen, and of course, if the father is RH positive, you go for maternal antibody screen at intervals of from 20, 24, 28 weeks, and definitely, you would do it at the time of booking a clinic. So if the antibody testing is negative, then you go ahead and administer 300 micrograms of immunoglobulins at 28 weeks, as most of you are doing. So at delivery of the baby, the RH status of the newborn needs to be checked. If the baby is RH negative, well and good, no further treatment. But if the baby is RH positive, then you need to administer 300 micrograms of anti-D within 72 hours of delivery. Now, if the father is positive, then you have to manage her as and suppose if the father is positive and the maternal antibody screen is positive at any of the gestational ages, then you manage her as RH sensitized pregnancy, where you go on doing serial antibody testing and titers. So earlier they used to go for invasive tests like amniocentesis and all that. But now, the good thing is right from 1990s, the best part is that, there's the non-invasive tool of doing Doppler ultrasound of middle cerebral artery, which can detect the fetal anemia at a very early, and it is quite sensitive test for actually detection of fetal anemia. So really, we don't have to do invasive testing like, doing amniocentesis for estimation of fetal bilirubin levels. So what are the precautions during delivery? You need to ensure that the consultant, that the neonatologist is there. Don't give oxytocics at delivery of anterior shoulder. Then if manual removal of placenta is required, do so gently. If blood transfusion is indicated, use RH negative blood only, and early clamping of umbilical cord is indicated, and leave a long length of cord about 15 to 20 centimeters. involve the neonatologist in the management of the neonate, send cord samples for ABO-RH typing, direct Coombs test, hemoglobin, bilirubin levels, and peripheral smear. So if fetus is Rh negative, no further intervention. If fetus is Rh positive, then determine the dose of Rh anti-D to be administered by a 4-step test. And what is this 4-step laboratory procedure? First, we do the Rosette fetal RBC screen for fetal-maternal hemorrhage. So if that is positive, then you go for acid elution or the Kleihor-Betke test to quantify the RBCs in maternal circulation, estimate the volume of fetal-maternal hemorrhage, and calculate the dose of Rh anti-D, which has to be given within 72 hours of delivery. So this is the Rosette test. On the left, you can see there is no clumping of RBCs, so it's a negative one. And on the right, you can see that because of the antibodies, that there is a positive Rosette test. So next, we have to look for the amount of fetal RBCs. And for that, you do the Kleihor-Betke test. So, but let me tell you that in India, because, normally we administer 300 micrograms of anti-D at delivery, which is enough for fetal-maternal hemorrhage of 15 ml. So really, we don't need to do Kleihor-Betke test. Some of the countries like the UK, Ireland and France, they are doing this test. But a lot of, European countries, as well as in India, we are not doing this test. Now, for sensitized women, management is guided by the following: presence or absence of history of affected fetus in previous pregnancy, example with severe anemia or high drops. Then you look for maternal antibody titers where no prior history is there. Sensitization may be determined by doing an antibody screen using ICT. So this is actually just, I wouldn't go into the biochemistry now, but this is how they do the indirect Coombs test, which you need to order, at the time of, for every Rh woman. So antibody tested this ICT, especially, if she's Rh negative, and there is, so in all these cases, you have to do an ICT. And this is, just a pictorial representation of how they do the direct Coombs test on the fetus. Okay. So now determining the fetal risk now. So now let's see, up to 40% of D negative pregnant women, they carry a D negative fetus. So the presence of anti-D antibodies reflects maternal sensitization, but does not indicate whether the fetus is D positive. So if a woman became sensitized in a prior pregnancy, her antibody titer might rise to high levels during the current pregnancy, even if the current fetus is negative due to an amnestic response. Now, if the father is positive, in 60% of the cases, he will be heterozygous at the D locus. In a D alloimmunized pregnancy in which the father is D positive, it is helpful to determine paternal zygosity for D antigen using DNA-based analysis. And if the father is heterozygous or if paternity is not known, the woman should be offered assessment of fetal genotype. This is all actually just elaborating, the flow charts, which I showed you in my earlier slides. Now, traditionally, it was done with amniocentesis and PCR testing, which has a positive predictive value of 100% and negative predictive value of approximately 97%. But these days, one can do a non-invasive fetal D genotyping using cell-free fetal DNA from maternal plasma, and the reported sensitivity of this cell-free DNA testing exceeds 99% and specificity exceeds 95%, and positive predictive values are similar to the older tests. Now, management of the alloimmunized pregnancy is individualized and may consist of maternal antibody titer surveillance, sonographic monitoring of the fetal middle cerebral artery peak systolic velocity, amniotic fluid bilirubin studies as they did in older days, and fetal blood sampling. So when you actually look for the titers, basically when the titer is between greater than 1 in 32 or between 1:8 and 1 in 32, that's when it is, that is the time when you have to go for middle cerebral artery peak systolic velocity. That means middle cerebral artery Doppler studies at serial intervals. at the gestational age at which fetal anemia developed in prior pregnancies is important because anemia tends to occur earlier and be sequentially more severe. So middle cerebral artery Doppler velocimetry, it is accurate and non-invasive. It is a non-invasive screening tool for detecting moderate to severe fetal anemia. It has a sensitivity of 100%, but it has a false positive rate of about 12% for fetal anemia. Use has resulted in up to 80% reduction in invasive testing, that is amniocentesis and chordocentesis. So not useful before 18 weeks of gestation, because why? Because the reticuloendothelial system is too immature to hemolyze enough cells to cause significant anemia. So it is also not a reliable predictor of severe anemia after 35 weeks. Welcome, Dr. Mrs. Anita Singh, one of our guest of honors. I've just seen you, Anita, in the picture. Yeah. So found to be similar or better than amniotic fluid optical density in the studies, which they used to do it in older days. Now, as you can see in this graph, that as the gestational age increases, you can see two lines, and the red one denotes the graph for fetus with severe anemia, and the lower one is for fetus without anemia or with mild anemia. So as you can see that the peak systolic velocity in cases of severe anemia increases at the rise is much more compared to the line or the graph without fetal anemia or with mild anemia. So this is just showing normal versus abnormal middle cerebral artery peak systolic velocity. You can see on the right that the peak systolic velocity in the middle cerebral artery is high. Now, management of, so what happens, how do you manage the middle cerebral artery Doppler? So now if, say, if the fetus is unaffected or mildly affected, what you would get a normal middle cerebral artery Doppler. You repeat the Doppler monthly, deliver at or near term after giving her corticosteroids for lung maturity. And, because these days, the upper limit, earlier they used to give at up to 34 weeks, but now, you give it even up to 38, 39 weeks. So in this case, there is, if the middle cerebral artery Doppler is normal, then there is low risk of intrauterine fetal death. Whereas if the fetus is moderately affected, the middle cerebral artery Doppler would be about 1.5 multiples of median. Then in that case, you need to repeat it at every 1 to 2 week intervals. You deliver after lung maturity, and enhancement of lung maturity may be necessary. Now, if the fetus is severely affected, in that case, the middle cerebral artery Doppler would be greater than 1.55 mom, or has frank evidence of fetal hydrops. In that case, you need to just give her corticosteroids for lung maturity and deliver the fetus as soon as possible. Now, these are some of the, the invasive procedures like, amniocentesis and checking, as I mentioned, so many times that these days we are not doing it. That was earlier on, they used to do to check levels of bilirubin in amniotic fluid. And the second one is fetal blood sampling and checking fetal hemoglobin level, which of course we do it these days once the middle cerebral artery Doppler is abnormal. That would be the next step, So these are, looking at what they used to use it, in 1970s and 80s, the Lilly's chart and the Quinon's chart to look for fetal anemia. So what you do now if your fetus is anemic? So recommended treatment for severe is recommended for severe anemia or hemolytic anemia in utero. So it is typically carried out between 18 and 35 weeks of gestational age and may be given intraperitoneal or intravascular, and ORHD negative packed cells with a hematocrit of 80% in use, an amount to be transfused. Now let me tell you, this is the formula for intraperitoneal transfusion, which is quite simple, which is gestational age minus 20 into 10. That is where the gestational age is greater than 20 weeks. Because why you need this formula, whereas if there is no facility for intravascular transfusion, or if the fetus is between say 18 or 19 weeks, then in those cases one can go for intraperitoneal transfusion. Now, this is a pictorial diagram of how they would do an intravascular blood transfusion, and there is a formula which is, you can see, which is the volume of blood which needs to be transfused. You need to calculate central volume for the particular gestational age multiplied by the final hematocrit. Final hematocrit is, like if the fetal hematocrit is 30%, you would want the fetal hematocrit to at least come up to 40%. So imagine if it's, 40% minus the initial, which is about 30, or it could be 20, whatever. So that needs to be divided by the hematocrit of the transfused blood, which is usually, which should at least be 80 to 85%. Now, the postpartum management of the neonate, baby should be admitted in the neonatal. I think this is a repetition, but an urgent, and this is what happens in the NICU side, or the special care baby unit side. An urgent exchange blood transfusion is indicated in moderate to severely affected neonates. And the pediatrician would give phototherapy for mild affectation. And now coming to antenatal anti-D prophylaxis, now in cases of abortion or termination of pregnancies, now there is 5% of sensitization, and the ideal dose which is recommended is only about 50 micrograms. But if you don't have 50 micrograms available, then you would have to give 300. That's the thing, because very few companies have this small dose of 50. Most of them, especially in India, have 300 micrograms or 100. And invasive fetal procedures, like there is 11% risk of sensitization, and there is dose of 300 micrograms is recommended in such cases. In cases of antepartum hemorrhage, 300 micrograms you give stat, to be repeated at not really 12 weeks. Sorry, this is an error. It should be repeated after 12 weeks in case of persisting APH. In cases of external cephalic version, there is up to 6% chance of sensitization, and the dose recommended is 300 micrograms. Now, a lot of people have doubts, what about, if there is a spontaneous miscarriage in those cases. Now, the RCOG or the NICE guidelines, they recommend, under 12 weeks, not giving anti-D for a spontaneous miscarriage. But, a lot of people would say that, there is no harm. And since, we are not doing the Rosette test or Kleihauer test, there is no harm in giving anti-D even to these women with spontaneous pregnancy loss. The normal amount of fetal blood that enters the maternal circulation is about 0.5 ml, and the dose of RH-IgG given is about 300 micrograms, which would actually neutralize nearly 15 ml of fetal-maternal hemorrhage, which I mentioned, in the beginning of my talk. So, and management is guided by the estimated volume of FMH determined by the 4-step lab test, which I mentioned to you, the Rosette and the Kleihauer-Betke test. Then the dose of RH-IgG given after sensitization is at least 20 micrograms per ml of fetal RBCs. So this is just a picture of how a baby looks with hydrops fetalis. They have pericard, and they have sonographically, they have pericardial effusion, pleural effusion, ascites. They could have a scalp edema, abdominal wall edema, and they could have placentomegaly. So coming to some take-home points, every woman of childbearing age should have her ABO and RH types done at first contact, and I'm very sure that most of you are doing it. It's just because sometimes, it's not documented, especially, what happened if you don't see the notes and, somehow it just misses, you miss it out in a busy clinic. It happen that, you may forget to treat her as per an RH negative pregnancy. Now, obtain the ABO-RH types for husbands who are found to be for husbands of women with RH negative, women who are RH negative, which of course again all of you are doing. Normally, we just request for the blood groups of both the partners at the same time. So normally, we wouldn't miss that. So ensure ICT, the indirect Coombs test, is done at 28 weeks of pregnancy with the appropriate prophylaxis. So normally, you would do it before you give, which means that before you give the IgG, immunoglobulin at 28 weeks, it is always better to do the ICT so that you know whether it is the antibodies are because of prior sensitization or it's because of the immunization, the active immunization through vaccination, which you have given. Now, a single postpartum dose may be inadequate in cases of severe fetal-maternal hemorrhage, and in those cases, but of course, as I mentioned, that because in India we are giving 300 micrograms, so which is enough for so it's good enough, and we really, but sometimes in rare occasions the fetal-maternal hemorrhage can be greater than 15 ml of which would normally occur during the time of a delivery. Now, what are the problems in our setting? Well, all of you would agree that the anti-D is costly, and there is lack of resources to adequately investigate and monitor the fetus in utero, especially in the peripheral setup. Then there is low turnout for antenatal clinics, meaning that you can miss cases. Then, because I mentioned, sometimes there can be poor documentation of prior sensitizing events. Some are, so that is one thing. The loss of case notes can happen, so you wouldn't know whether actually this woman was sensitized in her last pregnancy. And one more thing, sometimes, somebody has already, if she has been sensitized in her last pregnancy, you don't need to give her anti-D in this pregnancy because, she's already sensitized. There are some recommendations. Now, so we need to, what is important that is advocacy for partnership by government and NGOs to help subsidize the cost of the immunoglobulin. But this, I have been hearing for ages, but I don't know, it really doesn't, it has not happened so far. And special insurance cover for RH negative women to ensure ease of procurement when needed, then involvement of clergy as part of premarital counselors, and creation of special fora or groups for RH negative people where potential RH negative spouses can meet. So this is interesting. To conclude, RH rhesus alloimmunization is a real problem, and real efforts need to be made to mitigate its impact. Well, I do agree that the incidence of rhesus alloimmunization has really gone down, but still it has not been eradicated. And to quite an extent, it is preventable, but I do agree that, it cannot be prevented up to 100%. So although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain, and great advancements have been made in the detection and management of this condition, and many of our RH negative women can now have a happy obstetric career. So that brings me to the end of my talk, and thank you very much for a very patient listening. So especially, a second thank you, because at Monday evening, I know it's so difficult, at 6 o'clock. So with our attendees, whoever have logged in, I must say I'm really grateful to them, because really it's worth all the efforts which I have made in presenting this paper.
Thank you, Dr.
Nice to see you again.
Thank you, Dr. Pragya. Wonderful lecture you have given. And before we go ahead with the further proceedings of the webinar, I want to thank you. These flowers which you have showed and the butterfly are so lovely to see, and that helps us, to be very positive in these corona times, because nature is very unpredictable, and at the same time we are all corona warriors. So this is amazing and a wonderful presentation. I know a lot of efforts you have taken, madam, and really that is what is a Foxian, a learned Foxian who was at the helm of affairs of the Foxy Genetic Committee is with us. And there are many, many questions to you, but I will just take one question and we will get back to you, madam. This is a question by Dr. Sashikala S. Does all primi-gravidas need to be tested ICT routinely? Please, your take on this.
Yeah. See, now, I mean, as see, first pregnancies, I mean, usually the firstborn babies, as I mentioned, they are not that much at risk. Because,
Dr. Pragya, kindly stop sharing your screen. If you can just stop and then we can continue. Thank you so much. Yes.
Yeah.
Please go ahead.
I did mention that usually, the firstborn babies, they are not that much at risk. Because the quantity of the antibodies which cross from the mother to the fetus are actually in very small amount. It's usually the subsequent pregnancies which are more at risk. But if the RH, if the baby, but still, at least I would do an ICT. Because especially, I mean, if the mother is RH negative, because I have the facility and I would do it. And, as I mentioned to you about the grandmother theory, that some of them, even in the first, pregnancies, can actually have these antibodies present in them. So I would do an indirect Coombs test, even in the first pregnancy. So there is no harm. If you have the facility, it is slightly expensive, but I'm sure. But if you know that the patient is RH negative, please go ahead and do an ICT.
Yes, thank you. Yeah. Thank you so much. Madam, it is a pleasure to have you, and I still remember the days when we used to meet in 2015, 2017 and 18, and we are very happy that you have just recovered from a COVID. I know it was a very wonderful journey which you went through, but I'm sure you have come out more stronger now.
Not a wonderful, it was a harrowing journey. Not a wonderful journey. Yeah. No, I still remember the time when you came for BoxCon in 2014 December.
Yes.
And you gave a very nice lecture in which you presented your gynae oncology cases in Patna Obs and Gynae Society conference.
I had come that time, and I had also come in January 2015. Then, of course, it's been just going on. Okay, fine. Thank you so much, madam. Now I call upon Dr. Komal Chavan, the chairperson of the Foxy Medical Disorders Committee. She has been doing a lot of webinars, and she has finished more than 50 webinars by now. I don't think anybody has gone beyond your record. So I welcome Dr. Komal Chavan, my better half, and the lady who has organized this webinar. Please come over and take over this program. Thank you.
Thank you so much. Today, I don't know, being a Monday, still we were busy. We had one more webinar from the North India, but I welcome you all from Foxy Medical Disorders in Pregnancy Committee, and it is my privilege and pleasure to have roped in so many societies: Ranchi, Patna, Siliguri, Gangtok, Kalyani Society, and making this webinar happen. And we definitely had our guest of honor and chief guest, Dr. Dilip Kumar Datta and Gokul Das earlier, but now we have with us none other than Dr. Anita Singh, and she has come here and graced this occasion with her esteemed presence. Madam is the Vice President of Foxy. She's an ex-professor, Patna Medical College, past president, Patna Obstetrics and Gynec Society, was an earlier chairperson of Endocrinology Committee, FOXY 2014-16, member of Governing Council, ICOG. She's a chief consultant, JP Hospital, Patna, senior teacher, contributed many chapters in books, published articles in national journals, and we have been always hearing Madam and meet her in the conferences. Really, it is always a pleasure to have you with us and grace and give us, bless us and encourage us for this webinar of Foxy Medical Disorders in Pregnancy Committee. So, Madam, I would like you to speak and give a few golden words for all our participant panelists who are here present.
Thank you, Dr. Komal. And I take this opportunity to congratulate you for having such a aspiring, motivating, stimulating, supporting husband. There are so many adjectives to it that I could have added. And I wish the couple to go a long way in Foxy, like previous few couples who have succeeded in being on the horizon of Foxy in such a nice way. And I don't know, Dr. Niranjan, he gets energy from where? It must be you who is behind his energy and success and the activities that he is doing. So with these words, when you people invited me to be here in this webinar, I could not say no to Niranjan, but I had already committed to another program at 6 o'clock. But I said him yes, because I could not just think saying no to you people. So that was such a good gesture that you invited me for this program, and especially with Pragya having come back from such a bad phase of her life, I must say. We all had been waiting to hear her with her new face and new energy and new health. So it was very encouraging to see her and you, both of you. And I must welcome on behalf of Bihar, so Patna Obstetrics and Gynec Society especially, my co-guest of honor, Dr. Gokul Chandra Das, and the chief guest, Dr. Datta. And I'm so pleased to meet all of my friends, Dr. Suman, Anjana, Hafizur, everyone is there. So with that, I wish good luck to you and for your programs to go on like this only, even in COVID time and after the COVID time also. We'll be meeting personally with each other. Thanks a lot for inviting me.
Thank you, Anita Di, for making your appearance.
Yes. Thank you very much, Madam. This was very encouraging, and we really have to now meet in person. We are longing for that personal touch, but this web platform is keeping us all alive, and visiting 5 societies at one go is a great honor. So I'm having COVID or no COVID, we are going to meet and we are going to have academic exchange. And I also welcome Dr. Pragya Mishra. You had a very wonderful talk. You touched upon all the important aspects. It was really well presented, and thank you very much. Dr. Abha Rani Singh, Madam, I always very nice, very kind, and whenever I speak, she's very encouraging. Thank you very much for being the part of the webinar. I have these two young people, Priyankur and Hafizur Rahman. They are very energetic people, and really they are part of my committee and very active people. Suman Sinha, she's also a part of my committee from Ranchi, always conducting programs. I'm really happy to see my committee members in this webinar today, actively participating, and Dr. Anjana Jha. Welcome you all, and let's start the panel discussion, which is a most awaited feature of this webinar. Over to you, Dr. Niranjan Chavan.
Yes, thank you, Dr. Komal, for that wonderful introduction of our Vice President, Dr. Anita Singh Ji. Madam, and thank you for your kind words. Whatever we are all because of you, Foxians. And Foxians, all the time we think only about Foxian organization, and that is what makes us very, happy to be doing something extra for the society and our fellow members. Every day we go and do our routine work, and we go to our hospitals, we go to our medical colleges, we see patients, or we are on the phone nowadays with teleconferencing. But Foxy is bridging Bharat, like how Bharat Serum Institute, Bharat Serum and the Science Integra academic partners are doing right now is amazing. And that's how I can see Avarani Sinha, Anita Ji, and Pragya Mishra ji and all of you. I'm feeling so happy that I am right now in Chanakya or Moria, and we have a conference going on in those beautiful halls where Abha Rani Sinha had done that critical conference, I remember, and Anita Singh ji was at the helm of affairs of the AICOG Patna 2015. What a wonderful, beautiful climate it was. And we had none other than Shatrughan Sinha and Nitish Kumar, both the doyens sitting on the dais. And I was with Dr. Komal Chavan, and on one side I had Dr. Prakash Trivedi, one more doyen, and on another side I had Dr. PK Shah. So we are blessed with all of you, and we had a good time at Gaya, and Dr. C.N. Purandare, Madam, and Sir, and Madam Dr. PK Shah, we had all gone and visited that wonderful monastery there. And Patna, it's such a beautiful place, Madam, especially that hotel which you have, and the Mahatma Gandhi Stadium, and wonderful AICOG, Madam, with the red carpet. Thank you, all of you, to be with us. And with these words, I again thank all of you. We will go ahead with the panel. Dr. Pragya Mishra, please don't leave us. You are going to be here. You are the fetal chairperson, and there are many questions which have come. I will just take the names of those doctors: Dr. Vijay Shri, Dr. Sanjeev Shah, Dr. Shubhada Gupta, she has asked questions, Dr. Padma, Dr. Seema Parvekar, Dr. Manali Sevalkar, Dr. Varsha Gale, Dr. Shakuntala Yadav. There is one Dr. Niranjan Nayak also. So I would love to take their names, because that is what you want to hear from us, and we will take all your questions. And don't worry, if we miss those, you have that recording. I will send to you the recording on Science Integra YouTube channel, and we will get all the answers which have been said by Dr. Pragya Mishra. Thank you so much. Be there. I would like to share my slides now, and I welcome my panelists which are there for today. It's an honor and pleasure to be with Ranchi Society and Patna, Siliguri, Gangtok, and all amazing people. Dr. Komal, please be there to be with us. I'm the moderator. Just I'm sharing the slides. And we have Abha Rani Sinha, Madam. We have got Dr. Sumant Sinha, Anjana Jha, Hafizur Rahman, Priyanka Roy. Welcome all of you. I would like to add here a quote. This is by T.G. Thomas. In 1908, he told, and this is what he told: I recall nothing which in times past has caused me more anxiety and doubt, or in regard to which I have found it more difficult to get any satisfactory rules from books than the treatment of abortion. So what are the common questions which are asked by the RPL patients when they come to the doctor? Why did it happen? Will it happen again? How it can be avoided? Could have been avoided, and nowadays we can't interact, but surely we have to take that telecon and we talk to them. These are the most common problems which are coming across. Chromosomal abnormalities are 50%, and this is the percentage which are there. We all know what is the definition. More than 3 clinically recognized pregnancy losses before 20 weeks is a recurrent abortion, and the incidence is 1 in 300. Well, primary recurrent pregnancy loss refers to the couple that have never had a live birth, and while secondary RPL refers to those who have had repetitive losses following a successful pregnancy. And this slide is the most important slide of all the times. It tells us the genetics, the fetal anomalies, the uterine anomalies, immunological causes, hereditary thrombophilia, and we have got endocrine, immune infection. We'll try to cover as much as possible. And we have got experts from North and East India. And these are the proposed etiologies, the percentage of which are there. This is the Novice Gynecology 14th edition, and they give you what are the percentages. So, Madam, we start with Dr. Abha Rani Sinha. You can go ahead and read the slides, Madam. The ball is in your court.
Okay, so my case is a 25-year-old Mrs. M.S.J. who was married since 5 years. If I look at her obstetric history, in her first pregnancy, she had a vesicular mole for which a DNA was done. In her second pregnancy, it was a missed abortion at 7 weeks. DNA not done. She had taken pills. In her third pregnancy, again it was a missed abortion at 6 weeks, in which evacuation was done. And I think this is her fourth pregnancy at 6 weeks, where she had a blighted ovum and pills were given. If I look at her menstrual history, it was a regular menstrual history. The medical history, there's nothing significant. Family history, nothing is significant. Her clinical findings are normal. The hormonal profile is normal, and the RPL is negative.
Request all other members to please mute their mics. I request them to please mute their mics. Thank you so much, except Abarani Sinha.
When I look at the karyotyping, the husband has a normal karyotype, that is 46XY. But in the wife, we see a 46XXT, 1122, Q24, Q13. And this proband shows a reciprocal balanced translocation, which is involving chromosomal 11 and chromosome 22 breakage, and reunion has occurred at bands 11Q24 and 22Q13. If we look at the M-fish, there is a balanced translocation between chromosome 11 and chromosome 20, which is involving breakpoints 11Q24 and 22Q13 respectively. Well, the question, I think we have to go to the previous slide. Well, the point is that should we go for in this pregnancy, she is on pills and she is having a missed abortion. So should we go for the cytogenic study of the product of conceptors? Well, yes, because she has already already three losses. And in this pregnancy, we will like to know, at least we'll have an explanation that why she is losing all her pregnancies, and all early pregnancies, they are mostly associated with genetic causes.
Yes, ma'am.
Well, in the product of conceptors, we know that usually these abnormalities, they come de novo because of some meiotic errors, either during gametogenesis or during fertilization or during embryonic development. And the most common abnormalities that we find in the conceptors is the trisomies, mainly trisomy 16, and then it could be 22, 21, 24, and then the ploidies like polyploidies, tetraploidy, triploidies, monosomy, and in few cases we find this structural unbalanced translocation. And it is important that in these structural unbalanced translocations are the cases where we should go for a parental karyotyping. There is one point that if we find an aneuploid finding in a product of conceptors, we should not be worried much, because the studies have shown that the prognosis of the future pregnancies may be good even if she has an aneuploidy in her index pregnancy. Whereas even with an eploidy, she may have pregnancy losses in her next pregnancies. But still, we should go for the karyotyping of the product of conceptors, because we can get an explanation that why this pregnancy, she had a adverse outcome in this pregnancy. I think I'm clear.
Yes, madam, I'm listening, and all couples with history of recurrent marriages, recurrent miscarriages would be better to undergo this cytogenetic analysis.
Yes, I totally agree with you. And that is why I wanted to emphasize it. Now, coming to
the role of parental karyotype, please continue.
Okay. Now, coming to the role of parental karyotype, it should be selective. Like, we should do karyotype in those couples in whose fetuses we have found an unbalanced translocation, or if there is a history that they have given a birth to a fetus, to a baby who has not a baby, but the product of conceptors has shown an unbalanced translocation, or if they have even given a birth to a congenitally malformed babies. I think in all of these, because this parental karyotyping, it is giving us two information. Number one, it can give us the cause of the loss, and number two, it can also tell about the prognosis. And there are two types, and usually in the karyotyping, we find balanced translocation, which is the most important thing that we have to look for. And there are two types, common types of balanced translocation. One is the reciprocal translocation, and the other is the Robertsonian translocation. if I want to explain it, the thing, why we call it balanced? Because none of the chromosome, it is either lost or added. What happens in reciprocal chromosome translocation? A chromosome, two pair of chromosomes, two chromosomes, they just break and then they swap their genetic material. So therefore there is neither loss nor addition of the genetic material. Whereas what happens in Robertsonian translocation is that this usually occurs in the acrocentric chromosomes. That is the chromosome number 13, 14, 21, 22 and so forth. So what happens in this Robertsonian translocation, the centromere is there at the end of the chromosomes. And what happens that the two chromosomes, they go and stick to each other at the level of the centromere. And as a result, the short arm of the chromosome is lost. But though the short arm of the chromosome is lost, it does not contain any genetic matter. So it is still a balanced translocation. But when these couple, they are phenotypically normal, they do not show any abnormality. But when they conceive, that is, they pass on this abnormality as an unbalanced translocation, which can be either due to some defect in at the time of meiosis, and which can be either a trisomy or a monosomy. Any type of translocation will pass to the fetus. And the most common Robertsonian translocation is between 14-21 or 13-14. And as I said, they can present with a trisomy, which can result at times in a Down syndrome. Now, what is non-disjunction? Here we have to understand that normally during meiosis, there is separation of a pair of homologous chromosomes. If this separation does not occur due to some problem in the meiotic phase, then one of the fetus will get trisomy and one of the fetus will be monosomic. That three chromosomes will go to one and one will go to the other, so to the daughter chromosomes. So this is how the non-disjunction causes trisomy, as well as in some fetuses it may cause monosomies. Deletions. Now when deletions occur? Deletion occur at the time of DNA replication. What happens? Some part of the chromosome, it can be either detached or it can be deleted, or sometimes the whole chromosomal band may be absent. And these deletion, the most common one is the Cri-du-Chat syndrome, and that is deletion of the part of a chromosome number 5. And it has been found that the babies born with this disorder, they may be mentally retarded. And as we have rightly mentioned, the Cri-du-Chat is French for the cry of the cat. That is, the infant cries like the sound of a cat. Counseling. Well, it is very important, counseling, and if we get any abnormality either in the product of conceptus or in parental karyotyping, the couple should definitely be sent to a clinical geneticist to do the genetic counseling. And in genetic counseling, there are 2-3 important things. And the most important thing is the recurrence risk. And as you showed in your first slide, that the couple who comes, they always want to know what is the recurrence. They are so much anxious, they are so much worried, they want to know the recurrence risk. So the recurrence risk has to be explained. And the other thing is that in many of these disorders, we may go for a pedigree charting. That is, we may go for the chromosomal analysis of the family. So that can also help in coming to know the recurrence risk as well as to know the future risk. As you said, in balanced translocation, there is 5 to 10% risk. So all couples with a history of recurrent miscarriage should have peripheral blood karyotyping performed, especially if the product of conceptus shows an structural rearrangement disorders. If there are numerical disorders, we are not that worried. But if it is a structural rearrangement disorder, we are definitely worried, and these should be referred for parental karyotyping. But one point, Dr. Niranjan, I would like to mention that the collection of the sample of POC is very important, because if it is not corrected properly, there may not be yield of the culture, there may be maternal contamination. So I think that point should be taken, that it should be transported properly in the transport media which is given by the genetic lab. It should be washed in saline but should not be sent in saline, because sending in saline may cause loss of the membrane. So it should be collected properly and it should be sent properly, and That is very important to get a proper result. Though we are doing the conventional karyotyping, that is the G band, but now the time has come that we should go for the microarray techniques, because that gives us a better results, and for that we even need a less of tissue for that, and especially this viability point is not that important in microarray techniques.
Yes, madam, wonderfully explained. You're a professor, madam. The way you went ahead and explained what are the translocations, what is deletion, what is aneuploidy, amazing. And the way you have told, madam, there are many...
I tried to make it simple, Dr. Niranjan. I've tried to make it simple for people to understand.
Yes, madam,
and inversion, I didn't say, but inversion is also important, Dr. Niranjan. And in inversion also, there is no loss of genetic matter. What happens that a chromosome breaks at two places, and then the middle place, it gets upside down, and then it goes and reinserts in that place. So in that person who is having the inversion, it is a balanced translocation. But when this is transferred to the embryo, then this can again be unbalanced and can lead to chromosomal anomalies.
Thank you, madam. There are many comments which have come. We will take back to you. There are many people who are watching. I will get the exact figures very soon. It was wonderful to have you, a professor.
Thank you so much, Dr. Niranjan. Thank you so much. My pleasure.
Madam. We will come back to you. Now I call upon Dr. Hafizur Rahman, case number 2. Please read and start your presentation. Thank you.
Thank you, Niranjan sir and Komal madam, for giving me the opportunity. That is the case number 2. She is a 28-year-old lady, Mrs. XYZ, married since last 6 years, G4P1L0A3, with obstetric history. She had a preterm stillbirth at 7 months, with abruption, and the second pregnancy ended at a missed abortion at 6 weeks, and the third pregnancy again missed abortion at 8 weeks, and the fourth one as a spontaneous abortion at 8 weeks. So in the menstrual history, that is her menstrual period is regular with moderate and amount of flow and painless. The history of she had a medical history of childhood asthma and family history of diabetes mellitus and hypertension in the family. Now the routine investigations, it showed that is all her TORS profile, that is IgG mild to moderate, IgG toxa, IgG positive, rubella is IgG low positive, CMV is also IgG moderately positive, and herpes IgG mildly positive, but the M is negative in all the situations, that is IgG M is negative. Now other investigations show that VT is 3 minutes 5 seconds, CT is 4 minutes 25 seconds, platelet count is 1.2 log per 1.2, and the PT is 13, and the control is 11 seconds. Now the important it is that anticardiolipin antibody is the IgG is highly positive, as well as the IgG-M is positive. Lupus anticoagulant and DSDN is also positive. So that's important in the patient's history is there. Now the TORS profile is, so what is the distinctive features of TORS? So we can find in different situations for distinctive features of TORS, that may be in the force of intracranial calcification for toxo or cytomegalovirus, that there may be cataracts, and for especially rubella, then chorea retinitis, bone lesions may be there in syphilis and rubella, congenital heart disease may be in case of rubella, and microcephaly with cytomegalovirus. Now, what are the other infections that is the infection may be in the form of parvovirus B19, the HIV and syphilis and hepatitis and even the varicella can cause also the recurrent pregnancy loss. So those are there may be some role defects in coagulation profile, especially all the the factor V Leiden mutation, and those mutation may have is there. So infections, that is the sum of the infections that is we have mentioned, that is tuberculosis, and the other infection may be bacterial vaginosis, which is actually as an important cause, more of like in a late miscarriage. So genital tuberculosis has some implication. Those are more of a known like to cause implantation failure because of the intrauterine adhesions and the inflammations and the release of so many cytokines for the genital tuberculosis. Now, what are the mechanism in which the main important is that inhibition of cytotrophoblast invasion as well as differentiation and uteroplacental vascular thrombosis, which has been implicated as one of the main mechanism to cause thrombosis and ultimately the release of arachidonic acid and prostaglandins I2 decreases. So those causes the uteroplacental thrombosis, that is an inhibition of cytotrophoblast, that is more of a like causing the recurrent pregnancy loss with APLA profile, that is which we antiphospholipid antibody syndrome in those situations. Now the typical characteristic in losing the pregnancies, it will be showing that there is a gradual growth retardation and ultimately leading to a and the late first trimester and second trimester sudden loss of the baby, which may be seen around with antiphospholipid antibody syndrome around 5 to 25% of the patients, the pregnancy loss with the recurrent second trimester pregnancy loss. So those are the more of a like features. There are some other autoimmune now diseases which can cause pregnancy loss. Most importantly, in our clinical practice, we see that is SLE, which has actually a high rate of recurrent pregnancy loss. The other one is that's reproductive
I think Dr. Hafizur Rahman, we have lost the contact. He was talking about the recurrent pregnancy loss and immune causes and immunological disorders. So he has covered very nicely infections, and he has explained what are the implications of these infections occurring here. So basically, when we are talking about therapy in immunological disorders, this is what is recommended presently. We are not very sure how much is going to affect, but surely these things can be tried. There is also IV immunoglobulins, but it is little costly. So we have to consider either aspirin, low molecular weight heparin, or anti-paternal cell antibodies. And this is the management. Dr. Abarani Sina, if you are there, you can just guide us. In the meantime, Dr. Hafiz will join us. Please unmute, madam.
The treatment of APLA is always low molecular weight heparin along with low dose aspirin. That is the treatment that we give for the corticosteroids are not to be given, and there is no role of new things like intralipids, or these things do not have role, not intralipid, immunoglobulins. What we are giving is aspirin at the dose of 75 milligram per day and heparin, low molecular weight heparin. That is the gold standard for management of APLA.
Absolutely, absolutely.
And prednisolone and IV immunoglobulin, in desperate cases, people have given IV immunoglobulin. There are some studies, but still, it is not the gold standard for giving in cases of RPL.
Thank you, madam. And of course, there is immunotherapy. You can just read them. That's fine. Madam, please continue.
Yes, immunotherapy is passive. With immunoglobulins, what we need to regulate is the natural killer cells. And downregulation is associated with improved outcome. And this cytokine balance is altered by IVIG, that is intravenous immunoglobulins. I think this is a very famous study in which they had given IV immunoglobulins after 5 abortions, and the odd ratio was 2.1. Now these are the inherited thrombophilias. I think the important inherited thrombophilias are factor V laden mutation, the protein S deficiency, protein C deficiency, antithrombin 3 deficiency. Then there can be, but the hyperhomocystinemia has now come as a very important thing because it is associated with adverse pregnancy outcome. It can lead to preeclampsia, it can lead to placental abruption, as well as hyperhomocystinemia may be associated with neural tube defects. So I think, but as of now, it's not that hyperhomocystinemia, that thrombophilia for inherited thrombophilia screening should not be done as a routine. It should not be done. But if there is a history of a previous stroke or a family history or something like that, then in those cases we can go for this screening for inherited thrombophilias. Hyperhomocystinemia, of course, if we know hyperhomocystinemia, we have to treat it. We all know it is folic acid, vitamin B12 and vitamin B6. These three are given to correct hyperhomocystinemia, and of course low molecular weight heparin whenever there is any evidence of any disease which is associated with thrombosis. I think this much is enough.
Thank you, madam. You are always there, a professor, to guide us, and I think you have answered most of the questions related to immunological disorders. I think TORCH has lost its relevance. This patient came with the reports of TORCH, and I'm sure most of these reports you will find that they are positive IgG, IgM, but we are not that much doing very stringently, and even RCOG guidelines regarding TORCH has been seen that they are more towards immunological disorders. TORCH is not that much given precedence. What do you think, madam?
TORCH is definitely, it should not be done in, I think this message should go far and wide. It is not to be done in recurrent pregnancy loss. A big no.
Yes, madam. Thank you for those wonderful pearls of wisdom. And now we go to Dr. Priyankur Roy, case number 3. Dr. Priyankur, I know you are
Yes,
there.
sir.
Please go ahead and read your case. People want to see you and hear you.
Yes, sir. Thank you, Niranjan sir and Komal ma'am, for giving me this opportunity, and thanks to the Medical Disorders Committee for this opportunity. So, the case given to me is a 22-year-old female who presented with pain in the lower abdomen and right side in the pelvis, especially during her periods. Her periods were early and profuse, and severe pain in the lower abdomen which goes to the back. Feeling of excessive heaviness in the uterine region. The patient has had 3 abortions between 3 and 6 months in pregnancy. So just by going by the history, what should strike us in our mind? There are 2 things with the uterine size, and of course with the pain that is going towards the back and excessive heaviness in the uterine region, that is the bleeding, etc., which we can think of. The differentials that we can think of, one would be a fibroid, and the second thing that we could think of is a adenomyotic uterus. So comparing these 2, and when we give a history of 2 already abortion that has happened, and she's a case of recurrent pregnancy loss, then of course we need to accordingly manage the patient. Now the USG shows the posterior wall fibroid which is 4 into 6 into 5 centimeters in dimension. Now it will be a tussle between the heart and the brain. The heart of a laparoscopist say that we should go ahead and operate, but seeing the size, we will have a few more questions which we need to take, and thinking from our brain, it will be whether we operate or whether we don't operate. Now 2 things here. Sir, to the next slide please, sir. Yeah, so in this slide, once we see the size, we need 2-3 more answers that definitely I'm sure our viewers will also be looking at. One is we have the position, but we do not know whether it's near the conval region or not. Because when we are seeing at a case of infertility, and if the fibroid is near the conval region, we have something called a physical block, which sometimes causes a problem in fertility or in conception or even in implantation, because we see a lateral fibroid sometimes causes more chances of pregnancy losses and pregnancy failure, because the implantation of the placenta sometimes most likely occurs on the lateral wall of the lateral uterine wall, and because of a fibroid present there, the blood supply to the placenta may be less, and subsequently there might be a pregnancy loss. The second thing that we need to...
Yes, continue.
Yes, sir. The second thing that we need to look at, we have a size of 4 into 6 into 5. If you go by guidelines, ideally it's 7 centimeter. If you see a 7 there, you can think, okay, I should go ahead and operate. But we don't see a 7 here. But then since she has a history of 3 losses previously, so I think we should go ahead and do a myomectomy for this case. I guess we have done a myomectomy for this patient, because if the losses were not there and this was the first case, then definitely we could have said that, okay, let's wait on. And the position is again very important, because we need to know whether it's a subserous fibroid, intramural fibroid, or a submucous fibroid. This size, if it is a totally a subserous fibroid, then believe me, we do not need to do anything for this patient, just leave her alone. If it is an intramural fibroid, we will have to look at if the fibroid is indenting into the cavity or is not indenting the cavity, because indentation of the cavity is a very important factor that we need to keep in mind. So that reminds me that when we are looking at the indentation of the cavity, we definitely need to go ahead and do a hysteroscopy for this patient. So when we want to do this patient's treatment, one thing is hysterolaparoscopy, So, his consent has to be taken for a hysterolaparoscopy along with a myomectomy and then proceed with the patient in the theatre. Do a hysteroscopy first if you see the fibroid, or with the fibroid, sometimes the fibroid has a chance of getting associated with any septum or any uterine anomaly which can be corrected in the same sitting, and then we can proceed ahead, do a laparoscopy, see how the cavity is and see its relation, the fibroid relation with the situation of it, and then accordingly plan for a myomectomy, lap myomectomy in the same sitting. And definitely, let me tell you something, a very important factor over here is the consent. Please, for God's sake, do not go ahead with the patient thinking you will take a consent SOS in the OP after the patient is on anesthesia. Go ahead with all the consents if required. If you do not require to do something, please cancel the consent and tell them that we haven't done it. Because in medical legal books, the consent is very, very important. Yeah, so as sir is showing us that we have gone ahead and done a lap myomectomy. So we will see how we have proceeded with the procedure. Yeah, so this is the hysteroscopic finding, and we see both the corners, and then we proceed on. We will otherwise it looks all right. The cavity, yeah. So the laparoscopic finding, a beautiful picture. You see the uterus, the bilateral tubes and ovaries with spillage of free fluid down. So I'm very sure the tubes were open, and that's why the free fluid has come. We can see the fibroid beautifully popping out in the posterior wall, little on the right side, not near the conva. So we are injecting the vasopressin into the myoma basically by the needle, by injecting with the vasopressin injection needle, VI needle. And then after injecting the vasopressin, I'm very sure that the usual feature that we can see very clearly now is the white color thing that you see is the blanching basically. And it's very important for the blanch to happen. Followed by that, what we are seeing is with the harmonics, I is putting a beautiful incision on the myoma. It's a transverse incision. And transverse incision is very useful because suturing makes things very easy to suture. And here you see like a very nice ping pong ball that the fibroid has popped out. Sir is using a myoma screw beautifully, and I'm very sure he'll pull it out and the fibroid will easily pop out. So a very beautifully done myomectomy procedure, no bleeding at all, and whatever bleeding he can see over there, he is cauterizing it with a harmonic or with a bipolar. So that will make it a sort of a bloodless procedure. Yeah, so the fibroid is almost popping out from the capsule. Yes, beautifully done, and we can also see that the cavity is not opened. So, friends, let me tell you something over here. It's a very important thing. Cavity makes things very important, but then do not fear or do not be afraid even if the cavity opens up, because as per guidelines, suturing as sir is doing, even if the cavity opens up, it's a normal suturing. Only thing is we do not include the endometrium and we suture the myometrium into 2-3 layers. The important thing, like see, sir is using a beautiful barb suture over here for suturing, and he's doing the inside-out technique and the outside-in technique, that is a baseball suture technique. The very important factor when we are suturing a myoma bed is approximation. It's not how tight you make it. The more tight you make it, things become worse. So just approximate it well, make sure that there is no bleeding space that is left, and just suture it normally, and I think things will be all right. See, it's beautifully sutured bed, and you can see the bleeding that's collected in the POD is very minimal. I think it's less than 5 ml. So beautifully sir is sutured up, and you have seen that sir is closing in 2 to 3 layers, beautifully sutured up, and the technique also, and yeah, the other thing is cut the things very short. So this short suture cutting is possible when we are using a barb suture. This is the myoma. Now myoma can be taken out by 2 techniques. One is by morcellation, or other is by doing a colpotomy and vaginally. This is the open morcellation that sir is doing. This myoma looks quite inoculate. There is no malignant tissue or etc. that can be, I think, can be visible in open eyes, and it's beautifully come out. So just suck out from the POD. Or sir is also using an interseed in this case. Interseed is a good thing, but remember when you're using interseed, there should not be any bleeding around, because with bleeding, the interseed does not work very well. Patients who can afford, definitely interseed does wonders because it decreases the chances of addiction. So a beautifully done procedure, sir, and I really congratulate you, and I'm very sure after this procedure, because this was the only cause that we could see in this patient for this recurrent pregnancy loss, I hope that she has conceived and she has given birth to a child.
Wow. Priyankur, you gave a wonderful commentary to the video, and I'm amazed by your knowledge. And this was a catch question for an endoscopist, and it is a very important decision he has taken. You are not supposed to put a laparoscope inside just because you see a fibroid and she has recurrent pregnancy losses. Fibroid per se doesn't cause, unless and until it is a space occupying lesion in the uterine cavity indenting more than 50% or he said properly that it is near the corneal end, and that is the reason we had to take this case, and the approach was very rightly done, consent been taken, hysteroscopy to be done, and this is the last resort in that circumstances. And I'm happy to share with you this lady got pregnant in spite of all the treatment which we had done, and we discussed about heparin, low molecular weight, prednisolone, and all other things like protein, vitamins, B complex, etc. Complete bed rest. We evaluated her everything, but this was the last resort where we thought that probably this could be indenting. And I just showed you this endoscopy surgery, and Priyankur, you have done a wonderful justice to this case. And she became pregnant and she has delivered a baby that is now about 1.5 years back. I would like to thank. I would like to thank.
Congratulations, sir. And in this case, the heart and the brain both wins basically.
Yes, yes, you are right. And I would like to thank Dr. Hitendra Rajput and Dr. Shikanshi to edit this wonderful video and to add the music. Guys, you can still go on and see my YouTube channel, which is there by the name of Niranjan Chavan. There are more than 800 subscribers till now, and more than 60,000 views have been taken of most of the videos of endoscopic surgery and for cesarean section. And we move on to the next case now. Thank you so much, Priyankur. Be there. All of you, Abba saying, Hafizur Rahman, thank you for joining
sorry,
back.
sir, disconnected my internet in between.
Yes, and we just completed with Dr. Abha Rani Sinha the wonderful few slides of immunomodulation and immunotherapy, and it was nicely described by you. But be there. Thank you so much. We go to the next presentation, and I have with me Dr. I have with me now the next slide, which is there. Dr. Anjana Jha from Ranchi, please go ahead. This is your case. Please unmute your mic.
Yes. Thank you, sir, for giving me this opportunity and wishing you a great success in your coming election. This case is, can you hear me?
Yes, madam. Yes.
A 28-year-old woman, married since 6 years, approached to fertility clinic for secondary infertility for 4 years. She had 4 abortions in the past. She attended a health screening about a year ago and had an ultrasound pelvis done, which showed a separate uterus. She had a regular menstrual cycle associated with dysmenorrhea requiring regular simple analgesia, but did not complain of dyspareunia. I assume this case to be a mid-trimester abortion, and as we know, the most common cause of the mid-trimester abortion is congenital anomaly. And among congenital anomaly, septate uterus is the most common cause, about 70 to 80%. So first of all, in this case, I would like to confirm the diagnosis either by ultrasound, 3D ultrasound, or MRI. MRI gives us 100% accuracy. It can also be diagnosed by hysterosalpingography or hysteroscopy. Once the diagnosis is confirmed, I will counsel the lady regarding the pros and cons of the surgery. And if she agrees, I will admit her for the hysteroscopic resection of the septum. And at the same sitting, I will do the laparoscopy, lap and eye test also, and also look for the other congenital anomalies, if any. And after the hysteroscopic resection, she will be discharged on the first post-op day with 6 milligram estradiol valproate, and then I will call her after 4 weeks. With this woman, I will also look for the other diseases like the diabetes, the kidney disease, the hemoglobinopathies, and also exclude other conditions, the SLE, the inflammatory bowel disease, and I will also send one vaginal swab for the culture sensitivity. Regarding IUCD, some has opinion to insert the IUCD at the time of discharge, but I think there is chance of infection in the cavity, or it may cause infection in the tubes. So it can be given or not, but I will give her estradiol valiate and call her again after 4 weeks. At that time, I can also put a hysteroscope to see the cavity. And if her AMH and follicle counts are normal, AFC is normal, and the tubes are patent, then I will tell her to go for the natural conception. And I will also investigate her husband also, will not forget the male partner. And after surgery, there is a great chance of conception by the natural method. And she is just 28 years old. And I will wait for the 6 cycles. If she doesn't conceive, then I will advise her the IVF or the ICSI method.
Wonderfully explained by Dr. Anjana. Yes, madam, I interrupted you. Please continue.
Yes, then I will call her after again 6 months. If she conceives, well and good. If not, then I will suggest her either IVF or ICSI. That's it.
Dr. Abarani Sina is joining us now and she has to put her points. Please go ahead. Thank you so much.
Yes, sir. Just I wanted to have your opinion also that if the septum is extending up to lower down, should we do a routine os tightening along with the resection of septum? What is your opinion, sir?
I would love to do a uterine septum resection, and as which has been told now, it is very important to do a concomitant laparoscopy, which we'll be doing and seeing the patency. That is the most important thing.
Yes, yes.
Now, if you ask me about IUDs, I am not in favor of IUDs. Since you have opened a box, a Pandora's box of, a little controversy, because I would prefer that this uterine septum is given more of estrogen and later on also progesterone. Put a pediatric Foley's catheter number 14, inflated about 2 to 4 centimeter
do a pull-through test.
2 to 4 cc, not too much 10 or 12, because I don't want to hyperinflate, and then keep it for 7 days. But there are also studies which say that it is not necessary to be done. So what is important is basically this is to be done. And then if you have, there are studies where they have said and they have introduced IUCDs also, and they have gone ahead and they have showed results. But it is all the choice and affordability of a patient. India being a developing country, people can't afford to that extent the IUDs, which is with progesterone. And now coming back.
Can I just comment? Just a small comment, Dr. Niranjan.
Yes.
Because, especially the copper IUCDs, they are not inert. So what some people do, that they remove the copper part and then they insert the intrauterine device. The reason, that's the whole idea, when even myself, many number of times insert a Foley's catheter only, inflated. So that's also a good idea. But copper IUCD, just remove the copper part and then insert the...
Yes. So what is important now, once all this thing is done, we remove IUCD and or the pediatric Foley's catheter. Wait. See, when you have done a surgery, the idea is that adhesions should not reform. And there are de novo adhesions which are formed. So that is why she has to undergo immediately intrauterine insemination, follicular, stimulation. And then once she has her LMP, which is last menstrual period, missed her period, we need to go in action. And immediately she might require ICSI or IVF if it is more than 3 cycles. And then your question comes whether we should do os tightening. But madam, it has to be evidence based. So I would like to do her ultrasound. History, obviously, she has got recurrent pregnancy loss, but probably the reason was uterine septum, which we have removed. So still we will be going and seeing her ultrasound report. And if it is less than 1.5 centimeter, then we would like to go and do a proper circulage. We will come to the question about circulage. There is a case, we will discuss on that. But I think I have given justice.
Yes, thank you. Thank you, Dr. Niranjan.
Yes. Anybody else? So I think we will go to Dr. Suman Sinha now from Ranchi. Madam, the ball is in your court. You are going to discuss case number 5.
Good evening, everyone. Am I audible?
Yes, madam.
Okay. Thank you, Dr. Niranjan and Dr. Komal Chauhan. My regards to Dr. Anita Singh, madam, our chief guest, Dr. Dilip Datta, and guest of honor, Dr. Gokul Chandra Das. It's a wonderful opportunity, and now I present my case to you. She is a married female patient, aged about 31 years, and she has come to my OPD with the complaints of menstrual irregularities since 15 years, and she was anxious to conceive. She had previous reports of routine laboratory investigations, and it revealed that her married life was of 12 years. She had history of 4 consecutive 2 months spontaneous abortion. Can I have the next slide, please?
Yes, madam.
Yeah. And she has some imaging techniques report like diagnostic hysterolaparoscopy, and it revealed that uterine cavity length was 3.5 centimeter, and she had reported with irregular and multiple adhesions, firmly dense, and these features were suggestive of Asherman syndrome. Now the fundus and the bilateral ostial bicornua was not visualized due to adhesions. So, and she is anxious to have issue. So what should be done? This is my question. Since the if the report is recent one, it's okay, because what question I got where it was given that the report was very old. So I would like to first to confirm the cause, and it can be done by MRI or by sonohysterography. And the report is positive, then I would like to counsel the patient regarding the treatment about the disease, and my main aim will be to treat the cause, to prevent readhesion, to repair the endometrium, which I think that because of the repeated curettage, she might have gone due to spontaneous abortion, has caused has done trauma to the endometrium, and it might have caused so dense adhesion. So if she agrees, and then I will take a good history, and because her menstrual cycles were irregular, so I would ask what was her last LMP, and if she is not having proper menstruation, then I would like to give some hormones so that she has withdrawal bleeding, and then in the meantime I will go for some basic investigations which include all the blood investigations, urines, blood sugars, thyroid profile, ECG, what we do generally, even routine urine, and then I would like to admit her a day prior to surgery, and I'll plan for hysteroscopic adhesiolysis. This will be my plan of treatment.
Yes,
so,
madam. Now, I would like to go to Dr. Hafizur and Priyankur. They are endoscopists. Would you like to give some tips for Asherman syndrome, for doing the surgery? How would you go about? Would you like to do that in an office procedure, or would you like to take them under GA with proper consent? And then how would you do? Would you like to put some lot of water? What will be the distension medium? And how would you proceed? Would you like to use a scissor to cut, or whether you would like to use a cold knife, or whether you would like to use a cautery? Please guide us.
Sir, I use scissor. I have used scissor in this case.
Okay.
Sir,
yes.
This is Priyankur, sir. Yeah. So in Asherman's case, one of the important things is we all know that even the Durga Pujas are coming up. So before I go in with the case of Asherman syndrome, it's very important to pray God twice. Even if you pray twice, pray thrice and go inside, because it's a case which is difficult in even very experienced hands. So when I'm going in with the Asherman syndrome, so the very important thing is like what we do in septum usually, we cut from the center. But when we go in Asherman's case, it's very important for us to know that we will cut from the periphery. That is, we go from near the myometrium, we keep cutting slowly, and the distension media in this case, I will not use a cautery. I will go ahead with a scissor or a cold knife. Yeah. And
distension medium, what is the distension medium? What will be the flow, and what grade you would like to give? Suman madam and Priyank.
See, sir, I had given normal saline, sir. Normal saline, distension media.
Yes, Priya.
I will not use cautery, sir. I will go with a normal saline distension media, and I will cut it slowly with scissors or a cold knife, and no usage of cautery. And this will be it, sir. And other than that, one important thing in a case of Asherman's I always do is I always I try to use a dual setup, sir. That is, I put in a laparoscope as well, where I keep the scope on, and with a hysteroscope also I go from below. So when I'm slowly cutting, I don't know where the uterine edge is. So when I keep cutting and when I see the light, a little more of the uterine light, or the uterine is a little more, the uterus is a little lighted up, I know that I'm reaching near the end of the myometrium and I have to stop cutting over there. So that is one of the important things that I do, so that I do not perforate and go ahead without knowing where the edge is. And in Asherman's case, sir, it's very difficult even in experienced hands. So after I do the Asherman's case, it's the distension media with a normal saline. And then we have this debate of a copper tea or not a copper tea. But I still believe, I learned with Dr. Vineet Mishra, sir, and we used to put copper tea, and I still do put copper teas in my Asherman's cases, sir.
Okay, fine. I think wonderfully we have discussed all the cases, and I would love now to have the special guest with us, Dr. Anita Singh, Dr. Gokul Chandra Das, after hearing this, to give their special comments. Dr. Gokul Chandra Das, please come online, Dr. Anita Singh, and guide us if there is anything which you want to add, and you can surely inspire us. Yes, sir.
They don't know what to discuss. Happening much.
Yes, sir.
They have very good discussion. Agenda is very good. Thank you.
Thank you so much. I think there is some connectivity issue, and we had a wonderful presentation by all of you. I thank all of you to be present today. There are questions, and we have one more case which is there before we go ahead, and this is regarding incompetent os. Incompetent os is incomplete without taking the name of Dr. Shirorkar from Maharashtra. This is what is the monogram, and he has contributed in obstetrics and gynecology, and I want the Northeastern to know this. This was the E&S Livingston Limited, Edinburgh and London, which was the book published by them for Dr. V.N. Shirorkar, a great doyen, and we know what are the contributions he has given. He has given the Shirorkar cerclage, which is actual best cerclage, which is the best one as compared to the McDonald's, or you have the Benson's and Duffy's cerclage, but this is a very good one. And his other contributions also we know he has done for prolapse, and we know the Shirorkar sling operations, and this is what is very important. So, madam, coming back to your question, Dr. Amarani Sinha, cerclage is beneficial in 2 or more STDL or PTBs, and it is beneficial if the cervical length is 15 millimeters or less, or the internal loss is more than 15 millimeters, and this is very useful in most of the conditions except placenta previa, and we have to avoid this. And this is the nomenclature which we know, the old nomenclature and the new nomenclature, and the latest nomenclature is history indicated, ultrasound indicated, and of course we have the physical examination. We try to do the PV, we do the PV examination and find out what is the exact length, and if it is a short cervix, not dipping in the pool, but posterior vaginal pool, then that is where is the most common issues, where the cervix is short, and you have to combine all this thing with your experience of 25 to 30 or 15 years or 10 years, you have to go ahead and do. So with this, we would like to stop here regarding the panel discussion, and I would stop sharing here. We have few questions here which have been lined up, and I'm thanking you, all of you, to be here. There are questions which are there, which we can take, and this is to Amarani Sinha.
Yes, sir.
Dr. Amarani Sinha, there are questions which are there regarding basically about blood grouping. What are the blood groups which have been there and which are commonly seen in RH isoimmunization? Dr. Pragya Mishra also can answer this question.
Pragya is there, she can take, or otherwise I'll take.
Yes, madam, you're always there.
Yeah, I'm there.
Yeah, yes. Sure, Pragya.
Yeah, what?
Madam, this is regarding which are the blood groups which are more commonly associated with this RPL. That is the question.
With RPL?
With RH isoimmunization, sorry.
That's, yeah. Okay. Now, well, I'm not sure which groups, but you know what I know, is that, if there is blood group incompatibility, if there's APO incompatibility, then the incidence of RH isoimmunization is less, because, APO incompatibility has a protective effect. The reason is that even before, RH immunization starts, even before that, because of APO incompatibility, the red cells are destroyed. So RH incompatibility does not occur. But so I don't know about the group. The only thing I know, whereas if there is APO compatibility, then the incidence of RH immunization is higher in those cases.
Yes, yes. Okay. Madam, this is also regarding what are the chances of sensitization if anti-D is not given? Dr. Sanjeev Shah.
Yeah. If it is not given, then it can be very high, almost up to 16%.
Okay. Thank you. There is one more question.
16 to 18%.
Dr. Seema Parvekar has written here, when to give anti-D after abortion?
It's for all these cases, you need to give anti-D within 72 hours of the sensitizing event, whether it's a termination of pregnancy, or it's an ectopic pregnancy, or a molar pregnancy which you have evacuated, or even for normal deliveries. All, we need to give it within 72 hours. But if you have missed, then even if you give up to 10 days, that may still work.
Absolutely great, Madam. And it was such a wonderful presentation by all of you. And you have done your cases so well, Madam Amarani Sinha, Anjana ji, Suman, Hafizur Rahman, Priyankur, and of course the guidance of Dilip Kumar Datta, which was there in the beginning as a chief guest, and Dr. Anita Singh, who joined us in the middle. I would like to take this opportunity also to thank our chief guest, the guest of honor, Dr. Gokul Das, who had joined with us. And it was a lovely presentation by all of you. It is great to see that we visited today Patna, we visited Gangtok, we visited Siliguri. And I want to tell you, more than 1100 people have joined us today, and they are witnessing history being happening. And it is so wonderful to see those questions being answered by all of you and the way you are presented. And it is great to have you back. I will join back with you soon. Dr. Komal Chavan, would you like to say a few words? And then we would like to end this webinar with a presentation of a slide. Dr. Komal, I think she is
Just
busy.
one, Dr. Niranjan, somebody had posted one question saying that, whether anti-D has to be given after ectopic pregnancy and, after, medical terminations. So just for that person's knowledge, yes, you really need to. In fact, our COG guidelines, which have been archived now and they're under NICE guidelines, they say under 12 weeks, give anti-D only to ectopic, molar pregnancies, medical termination of pregnancy, or if it's a case of threatened miscarriage with repeated bleeding and persisting abdominal pain. In fact, they don't recommend for just a single episode of threatened miscarriage. But we, in the Indian scenario, somehow, we tend to give even after a threatened miscarriage. So I hope, so just to reiterate, you really need to give anti-D after ectopic pregnancy or evacuation of a molar pregnancy. That is for that person.
Yes, yes. Thank you. Thank you all of you being there. I would like now Sana to show the slide, please, which is there. And
thank you, Dr. Niranjan and Dr. Komal. Thank you so much.
yes, make sure it is connected before we start talking. So there is a proper connection between the brain and what you talk. Don't take me otherwise with this picture. I present to you all today, but time and again, this is what all my seniors, teachers and gurus have taught. And this holds true now all the more as we are on a boundaryless content platform. That is a TOG platform. The world is seeing us and we need to give the show the best in the content, and that is who we are. at Foxy. Once a Foxian, always a Foxian. Thanks, ladies and gentlemen, for your patient hearing and joining with us. It was a pleasure to be here.
Thank you, sir.
Thank you very
sir.
much.
Thank you, sir.
Thank you, everyone.
I really enjoyed.
Thank you, Dr. Niranjan, for being such a brilliant moderator for today.
Yes, thank you. And for giving us the opportunity to be with you. That was the best part.
That is to Komal. Komal.
Yes. Komal.
Both Komal and Niranjan, they go hand in hand.
And in one's
Thank
name
you
is
so
enough for
much,
both.
everybody.
Thank you
And
so
thank
much.
you,
sir.
and thank you Science Integra team for doing such wonderful webinars. All TOG webinars are very nice.
Very nice. Thank you. We enjoyed, really had a wonderful time. Bye, everyone.
Thank you.
Bye, madam.
Bye.
Bye.
Bye, Ranchi.
Nice
Bye,
meeting you
Patna.
all.
Bye, Gangtok. Bye, Srinagar.
Bye-bye.
Monsina, Integra.
We will catch up soon. Thank you.